Hello friends, this is a case of robotic myomectomy and we will use Da Vinci robot to perform the robotic myomectomy. Here we are introducing the varus needle that is approximately 5 centimeter above the umbilicus and that we will use for the optical port. So, this is a deep intramural approximately 8 centimeter of the myoma and we will remove it by Da Vinci. So, we can see here this is suction irrigation and hanging drop test just to make it sure that the varus needle is inside the abdomen and now we are creating the pneumoperitoneum. Pressure is 15 and actual pressure slowly is increasing. Initially it should be single digit and slowly it will increase to 15. We can see the homogeneous distension is started and the abdomen is inflating with the carbon dioxide. So, we are watching the insufflator and as soon as the preset pressure and actual pressure will be equal, then the flow will stop and then we will remove the varus needle. So, this is a interesting case. This is a nulliparous omen. We are not using any uterine manipulator or any other port. And this is the optical port. As you know that optical port in Da Vinci, you can use any port. So, here we are using regular, but the working port of the Da Vinci, you should must have the Da Vinci port, that is 8 mm. So, this is the optical port is introduced. Now, the gas is reconnected and maximum flow rate is increased to. And now we are introducing the robotic telescope inside and then we will do the initial examination and after that under vision we will put the another working port. So, here we are using the two contralateral port we will use and one the assistant port we will use for suction or for dropping the needle or to help. So, these are the Da Vinci port. We can see this is 8 mm port and it has a remote sensing, that is a remote center is important to remain in the abdominal wall. So, you cannot use the any other. This is the intrusive port, Da Vinci port, which is must for the working port. So, these are 8 mm port and we will put two contralateral port to form the baseball diamond concept. So, this is the third port which we are putting and these two contralateral port has the advantage that you will have the easy suturing knotting and one more port we will put the laterally for the assistant to put the needle or to put the suction. So, these all the port is introduced and we are viewing on the vision card of the this Da Vinci. So, these all the three port is introduced. After that we will do docking first. So, the patient side cart of the Da Vinci will be brought from the lower edge here because it is an unmarried girl. So, we are not keeping in the lithotomy position and it is a complete flat supine position and we are docking the. So, first we have to dock the optical arm, that is the middle one, and slowly the master controller one switch will be pressed so that you can take the robotic arm at the level of the cannula and then it will be docked. So, docking process is very important in robotic because if you will not dock it properly and the ports are not at correct place, you will struggle during the surgery. So, this is the optical port is docked and now we will put the side port under vision already. Trocars are already in, so now docking will be just you have to connect the arm with the your operating ports. So, this is now the left side and then again the right side will be also docked. So, once the docking is complete, then the control goes to the surgeon because only at the time of docking and these are the instrument we are introducing it. So, we will use the different instrument at different time and it will produce instrument has 10 usage in the robotics. So, we are sterilizing those instruments with the plasma sterilizer and on this is the viewport of the Da Vinci. We have two robot, one is Da Vinci, another is Mantra and time to time we use these robots. Sometime we have the newer robot also So here it is 3D HD, and this is the Da Vinci SI HD robot. So this is the but console here we are using, that is the SHD. So these are the different button, master controller, display, working distance. Today the most advanced Da Vinci is Da Vinci 5 and Da Vinci XI. This is little old model, but we have the newer one also, and Mantra robot also we have. So this is the emergency stop, this is the power button, home button, and these are the master controller. This is U port in which you will put the head, and then you have a completely 3D high definition image. So let us start the surgery now. These are the master controller, and your finger, that is thumb, will be in the black hole, and this is how you will input the master controller, and then your movement of the hand will be translated in the robot. It will be translated inside the abdomen. So let us enter inside and start our surgery. So in this is first what we have to do. We have to take the vasopressin just like how you do in the open surgery. Here we can see left side we have the atraumatic grasper and right side is seizures. So this is a uterus, and here it is a very nice pelvis. There is no endometriosis, there is no any adhesion. Ovaries also look good. Fimbrial end of the tube also look good. And here we are waiting the assistant to bring the aspiration needle and to inject the vasopressin. So here 5 international unit of vasopressin will be diluted with the 20 ml saline, and then we are injecting it, and we can see this is the bleeding has started, and it will create the transient ischemia, and marble white appearance will be there. So this is injecting. After that we will start our incision. So this is the anterior wall myoma, but it is a deep intramural myoma. So right side we will attach with the monopolar. So right side is a monopolar seizures, and left side is a grasper. So we will activate with the monopolar and then cutting the seromuscular layer. We have to take care that tube should not be damaged, and here we are supporting the uterus with the left hand grasper because we are not using any kind of uterine manipulator. So this incision is given by the monopolar seizures. After that we will catch the edges of the seromuscular wall, and slowly we can see the capsule of the fibroid is visible. So this is a quite good plane. We can see this is the capsule visible. Now we are using little suction to suck the some oozing is there, that is better. The incision length of the uterus generally in robotic or laparoscopic myomectomy is 2/3 of the size of the myoma. So good incision is required because you don't have a finger, and enucleation you need to have a good plane. So we can see this is a good plane, and now we can try to remain on this plane. This is a atraumatic grasper, so little slipping. So here we will ask our assistant to put a myoma screw, and that will help to give the traction over the myoma. Ideally in laparoscopy we keep myoma screw in our own hand, in the left hand, and with the right hand we do enucleation. But here you have to be careful that you need to tell your assistant to do that. And one more very important thing is that you should make it sure that when you activate the monopolar seizures, It should not touch the myoma screw, otherwise there is a chance that it can create direct coupling. If you use tenaculum in the left hand, then holding the myoma is little easy with the tenaculum. But here we are using the atraumatic grasper. One of the challenging part of the robotic surgery is that in open surgery you have a tactile feedback and your finger does a very good job to put it. In laparoscopy also we have little tactile feedback, but in robotic you don't have absolutely any tactile feedback. So you have to only dependent upon the visual 3D visual cues, and according to that we have to separate it. We are also careful that the cavity should not get opened. Sometime in some of the gynecologists they start the patient with the GnRH and then make the fibroid soft. So generally in the myomectomy, generally in laparoscopy or robotic, prior to the surgery we should not give the patient the GnRH because that will make the surgery difficult. So we are reaching to the base of the fibroid, and just now the fibroid is about to come out. We will do little coagulation of the muscle, but better strategy is just to take the fibroid out and after that start suturing as soon as possible, because once the fibroid is inside then coagulation is more difficult because edges will not be visible very clearly and the vessels also can be missed. So we are taking care that the cavity should not open. So we are trimming the upper part of the fibroid and the remaining part we will take it once the bigger main bulk of the volume of the fibroid will be removed. So this is just about to come out. And it is major bulk is removed. Now the remaining part we have little bit trimmed out and then the suturing will start. So this is the muscle layer which will start its suturing. Here we are not using barb suture, this is simple vicryl. So this is the starter knot. We started with the surgeon's knot. During suturing you have to be careful that you have to depend upon the visual cues, because we absolutely don't have any tactile feedback, and sometimes if you are over tightening the suture can break in robotic surgery. However, in the Da Vinci 5, which has recently launched, it has a force feedback, so you can get some tactile feedback by the haptic feedback. So we may have to ask assistant sometime to hold, or other alternative is that you can use tumble square knot, so that muscle will be approximated. We can see suture is broken, so we have to cut it, and again we need to restart. So we will, this suture is too small, so now we will take it out, and we have to introduce the another suture. So after removing the vicryl, now this time we have introduced the barb suture. So that will definitely make the surgery and suturing easy, because you don't have to tie the knot, and it has the advantage that it has a loop in the beginning of the suture. So through you can pass through this loop, and it will be self locked, and it is unidirectional. As we know that we have different type of barb suture like V lock, strata fix. So this is the V lock suture, and we will introduce with the healthy serosa, and then we will start with the muscle layer. There was two bite was taken at the place where little bleeding was there, and this is the loop which will pass through, and then it will lock. Here assistant is holding the suture and giving traction, so that it will be uterus will be little anteverted, and then further suturing will be little easy. Here we are planning to suture it in 3 layer. The first deeper layer was taken in the bite, and then this is the second layer, and again we will return to the outer muscle layer. So 3 layer suturing we will perform. Now this is returning second layer of the deep muscular bite. So suturing has both the purpose. One is to reinforcement and give a strength to the muscle, and another, if there is any bleeding, it will stop. So, this is reaching to the left edge, and now again we will return back to the right side with one more muscle layer, that is the superficial muscle layer we will suture. So, now suture is very small, so we will cut it, and as you know, in barb suture you do not need termination because it is unidirectional. So, you can just cut it, you do not have to worry about the termination knot like Dundee jamming knot or other knot. And then we are waiting for assistant to drop the another suture. So, we will further continue. In the robotic, the assistant has to drop the suture because you do not have an option to take it yourself and introduce it in, because whatever robot can do, it can do only inside the abdomen. For any external entry you need assistant, and here it is another barb suture which is pulled in. So, now everything looks good, there is no any bleeding. So, the final layer of the suturing will be started, we will do for the serous layer. Here you may ask your assistant to hold the serosa after taking the suture, so that it can give you little traction. Margin should be kept inverted. However, in this patient we are planning that Once the suturing will complete, then we will put interseed, that is reoxygenated cellulose for the adhesion prevention. Now we have some remaining sutures. So we'll just take couple of reverse bite so that the oozing what you can see will stop where you have taken the prick. In robotic, taking the bite backhand also is easy because tip of the instruments are articulating. So you can go from below up also equally easy even with the right hand. So now we will terminate it after reaching to the right side and locking it once. And then tightening it, and assistant can cut the suture. Little oozings are still on the prick margin of the needle, but that will stop itself. If you want, you can take one more deep bite, but most of the time with the pressure it stops. So now the needle will be taken by assistant, and then we will do final suction irrigation, and we will use a endo bag to remove the fibroid. So we are waiting for assistant to drop the endo bag. This is a commercially available endo bag. By the time we will check all the fibroid and fragmented tissue from everywhere, we'll keep over the one place. Check the cul-de-sac. Here our main fibroid is sitting. Suction irrigation is doing the final suction irrigation, so that all the fragmented tissue also can, a smaller one, very small particle can be sucked, and we will do also it at the end also. So this is a self-made endo bag, simple polypropylene one. So you can ask your assistant to hold it, or you can give it to your assistant to hold it, and slowly all the tissue you can take and drop it inside. Here we will not use modulator. If you want to use modulator, then you have to use more safe endo bag. But here we will use the ovum forceps, fragment it and take it out by the port itself. We should carefully look at all the part, and any of the piece of the fibroid should not be left. It should be sucked nicely. These are the fragmented tissue. All should be collected in the endo bag, because sometimes it become like a satellite fibroid. However, these are very young patients, so there is no chance of malignancy. Sarcomatous changes are extremely rare in very young patient, but then also it is very important that any of the tissue should not be left inside. Even the smallest what you can see should be kept in the endo bag, and then you should remove it carefully, so any fragmented tissue should not be dropped into the abdominal wall wound also. That also latter you should clean it very nicely. So checking all the bowel loop, checking these are clots, so these are nothing. So you can suck those, and final inspection should be done. So there is no much difference in the robotic as well as laparoscopic myomectomy. And frankly speaking, I will tell you that I feel laparoscopy easier than robotic, because it is taking less time for me to do the laparoscopic myomectomy, and we have a little better tactile feedback in the laparoscopy compared to robotic, because I can hold the Myoma screw in my own hand, and then ambidextrity is easy because pulling and pushing you can do with the equal and opposite force, which is completely lost in robotic. But slowly now in the new generation of the robot, once the force feedback, that is also called tactile feedback, will come, it will be easy. So thank you very much for watching this video. This was just a simple case of robotic myomectomy. Here again, final suction irrigation, careful removal, finding out. However, the 3D vision and the motion scaling and the wrist articulation, these are the things which make the robotic surgery little better, and moreover suturing knotting is little easy. But in the expert hand, even the laparoscopic suturing knotting is not difficult, and you can perform with the equal advantage. So now after final inspection and suction irrigation, once it is complete, this patient ovary looks good. These are the follicular cysts, so these are not the ovarian cyst, and everything is fine. Now we have to do one more thing, that just to prevent the adhesion, we will use interseed and we will cover this entire suture area. Now you can see there is no bleeding, no oozing, there is no active bleeding. These are the just little blood which was over the serosa. So if there is any active bleeding, you will see a trail of the blood, which will like a snake in the river. You will see the trail of the blood will be visible. So now we are waiting for assistant to take these endobag mouth out, and this is the interseed, that is reoxygenated cellulose. It acts as a mechanical adhesive barrier. It looks like a mess, but consistency is just like a tissue paper. So you should try to immediately spread it, because if you will keep it over the bowel, or if it is wet, it has a tendency to stick to the bowel. And another problem is that once it is wet and then you try to spread, it tears, it split. Just like a wet tissue paper, you cannot spread. You can put little saline over that so that it will stick to the part of the suture. So this is done. This was little large, so we have put double layer. That is good. And now the removal of the tissue and port closure you have to do manually. Remember, robot doesn't do port closure, so that you have to do under vision, and port closure is very important in these patients, because hernia can happen especially through the port through which you have removed the tissue. So that is important. So thank you very much for watching this video. It is over now, and have a nice day.